And that being said, thank you for joining us. We will go ahead and begin today's webinar. So good afternoon, everyone. Thank you for joining us for today's webinar, Planning for Safe Care, What Family Drug Courts Need to Know About Serving Pregnant Women with Opioid Disorders and Their Infants. My name is William Moore, and I am with OJJDP's National Training and Technical Assistance Center. As your technical host, I'd like to take a couple of minutes to discuss a few features of the Adobe Connect webinar platform and provide a few announcements to keep in mind. Please note that this event is being recorded and will be published on OJJDP's INTAC's YouTube page. The webinar recording will be archived in approximately 1 week on OJJDP INTAC's YouTube channel, where you can also view past webinars. For the event transcript and supporting materials, please contact the OJJDP TTA Help Desk on the information on this slide. For those wishing to download a copy of the PowerPoint slides and other important documents, you may do so by locating the Handouts pod directly above the chat area. Here, you will also find an FAQ for webinar participants that will likely address any technical related questions that you may have. Click on the file name and then click the download button. During today's webinar, there will be a Q&A session where the presenters will address some of the questions posed during the presentation. Type your question into the chat box as they arise. Please do so by following the directions on this slide. For those participating in today's webinar as a group, please take a few minutes to help us count. Go to the chat window and type in the total number of additional people in the room with you today. If you are viewing alone, there is no need to type anything into the chat pod at this time. Thank you. At the conclusion of today's webinar, you will be provided with a link to a brief survey about today's presentation. The feedback you provide is used to assist in future planning and training. And also following today's webinar, attendees will be sent a certificate of attendance. This certificate is sent approximately 1 hour following the conclusion of the event and is sent via an Adobe Connect thank you email. Please keep an eye on your email for your certificate. Finally, please take a few minutes to review the acknowledgement on this page. Again, thank you all for joining us today. I will now turn it over to Jill Gresham for today's webinar.
Thanks so much, William, and welcome to everybody across the country joining us today for the webinar. We're going to be discussing safe planning, plans of safe care, and how to support pregnant women with opioid use disorders in the court. Again, my name is Jill Gresham, and I'm a Senior Program Associate with Children and Family Futures. Over the last 4 years, I've been working with states through the National Center on Substance Abuse and Child Welfare's In-Depth Technical Assistance Program, or IDTA. These states have been focused on addressing infants with prenatal substance exposure and more recently on implementing plans of safe care and aligning state policies and legislation with federal changes in the Child Abuse Prevention and Treatment Act. So before our discussion, I'd like to get a little bit of a sense of who's in the room today. So we're going to do a couple of quick polling questions, if you can pull those up for us. So you should be able to see the first polling question. Are you currently working in or partnering with a family drug court? So you can say yes, no, or uncertain. Give you just a minute or so to fill that out. And it looks like it's slowing down, so we can broadcast that. So it looks like we have about 54% saying yes, they're working with a family drug court, and about 41% saying no, and about 5% uncertain. So a pretty even split there. And can we open the next poll? Last polling question here on this. What system or agency do you represent? Child welfare, substance use disorder treatment, legal or the courts, healthcare, community service organization, research or evaluation, or other, and you can type that into the chat box. Great, let's go ahead and broadcast that. Looks like it's slowing down. So it looks like we have heavy representation here from child welfare today as well as the court, so almost an even split there. Glad to see lots of folks coming in from substance use disorder treatment as well. Seeing folks also across the board from healthcare and community service orgs and other folks as well. Thanks for that. We can end that poll. So before we jump into our discussion with our panelists, I just want to take a brief minute to review plans of safe care and the new federal CAPTA legislation. So the changes that were made to CAPTA, the Child Abuse Prevention and Treatment Act, were actually done within CARA, which is the Comprehensive Addiction and Recovery Act. So all registered attendees would have received a pre-recorded webinar that laid out some of the issues with Plan of Safe Care. If you hadn't had a chance to review that, it's not a big deal. You can certainly do so after we finish up today. So CAPTA's been around since about the 1970s, and we can go ahead and move that slide forward. CAPTA itself is a broad piece of legislation that affects many aspects of child welfare practice. However, when we talk about CAPTA today, we're talking about a very small slice of CAPTA that applies to infants affected by prenatal substance exposure. So in 2003, CAPTA was amended to include language that directed healthcare providers to notify child welfare of any infant born affected by illegal substance exposure or withdrawal. CAPTA at that time went on to direct providers to also implement a plan of safe care for those infants. There was an amendment that happened in 2010. It was a fairly small amendment where they just added fetal alcohol spectrum disorder to those infants. So illegal, exposed to illegal substances, affected by illegal substances, withdrawal, or FASD required that notification and also the plan of safe care. In 2016, we saw several changes happen to the CAPTA legislation. A lot of it was driven by the opioid epidemic and some infant fatalities and things like that. But the big piece was that they struck the word illegal. So previously, the legislation called for infants affected by illegal substance abuse, withdrawal, and FASD. Now the language is infants affected by substance use, withdrawal, and FASD. So this means, substance abuse, this means that an infant exposed to a prescribed substance such as methadone or other medication-assisted treatment would require that notification and would also require a plan of safe care. So and the other big change was where previously the plan of safe care only applied to the infant, it actually has been broadened to now apply not only to the infant but the primary caretaker. In many situations we're talking about the mom. And the last big piece that changed was that the law required states to start reporting data up to the federal government, including the number of infants who had been born affected, the number of plans of safe care that had been developed, and the number of those plans that included referrals for, again, not only the infant, but also that primary caretaker. Lots of folks have questions about what is actually a plan of safe care. I think the one big piece to recognize is that it's not a safety plan, but it really is a tool for collaboration. It's almost a melding of the safety plan, of the medical plan for the mom and for the infant, a developmental needs plan for that infant. That substance use disorder piece would also be in there for the mom. And while CAPTA says the plan needs to be put in place at birth, what we found working with many states is that a prenatal plan put in place could actually start to avoid a crisis at that delivery moment and help providers plan for that infant to be born. The CAPTA law also doesn't mandate who needs to oversee the plan of safe care, and in many respects, family treatment courts would be ideal to oversee both that prenatal plan of safe care and also the plan of safe care developed at birth. So family treatment courts are already practicing collaboratively with their partners. The plan of safe care could be another tool in their tool belt to support families. So today we're going to talk about how to address that prenatal period of time with Dr. Turplin and how to further support families as they move through the court process with Judge Rowley. Let me introduce them. Dr. Turplin is a professor in obstetrics and gynecology and psychiatry and associate director in addiction medicine at Virginia Commonwealth University. He's dual board certified in obstetrics and gynecology and in addiction medicine. Welcome, Dr. Turplin. And Judge Rowley was first elected to his position in 2000 and reelected in 2010. He served as an acting Supreme Court justice since 2003 while presiding over an integrated domestic violence court. In addition to his criminal court, family court, and surrogate court caseloads, he presides over 2 other specialty courts that he founded, the Family Treatment Court and the Sexual Offender Compliance Court. Welcome, Judge. Thanks for joining today. So my background is substance use disorder treatment. I worked many years in residential. Many of the families I worked with were involved in the child welfare system. I learned the benefits of collaboration in long-term residential treatment pretty early on, but really more than that, it was an honor for me to be a part of the journey that my clients were taking. Although it was hard and painful at times, it really motivated me to give them every tool that they needed to reconnect with their families. We're fortunate to have the both of you today who are very influential voices. We know that in your respective positions you have opportunities every day to motivate, inspire, and guide. So I really want to start off with this question for each of you, and I'm going to start with you, Judge Rowley. Why do you care so much?
I hate that question. It's hard to give a simple answer to, but I've always been a motivated, energized person. But I'm not really different from anybody else, and certainly not from our parents. I mean, I want my life to have meaning. I want to have an impact on the world, and I've gotten smart enough as I've aged to realize my world is my community. I used to think it was the whole earth, but now it's down to my community. Working with drug courts gives me a chance to witness their remarkable healing that can happen with families, but as you say, also the heartbreak of working with these families. I find it very rewarding, and I think that a lot of family treatment court professionals are drawn to the field for the same reason.
Mm-hmm. Thanks, Judge. How about you, Dr. Turplin?
Well, thank you, and I guess I will echo the hate that question. I mean, it's more like the inverse. Why doesn't everybody care so much? Seems to be more pertinent, perhaps. But the judge said a couple of things that I just wanted to reflect back. He talked about meaning. He talked about witness. I think it's, like through witness, we actually create our meaning and our purpose. And as a physician who takes care of women with substance use disorder, I find it like a privilege and a really wonderful place to work and to practice. And in particular, most pregnant women do very well in treatment, and it can be an incredibly reaffirming and positive time to engage with not just with an individual, but with a family and with a community.
Absolutely. The change is dynamic and amazing. We're going to shift and talk a little bit about stigma. It's something that we have come up across in pretty much every state that we've been presenting in recently. Before we jump into the stigma question, I think we have one last polling question around the use of medication-assisted treatment. There it is. Please indicate your level of agreement. And medication-assisted treatment, prescription drugs that treat opioid addiction should be made available to pregnant women. Strongly agree, disagree, neutral or uncertain, agree, strongly agree, or no vote. All right. Looks like we have a pretty good cross-section there. Most folks in that strongly agree or agree column, but definitely have some folks that disagree or are neutral or uncertain. You can end that poll. Thanks everybody for participating in that. So let's talk a little bit about stigma. So one thing that we've seen most places that we go is how stigma can really negatively affect the implementation of effective practices for this population. So Dr. Triplett, I'm going to start with you. What's the most common misunderstanding about women with opioid use disorders?
Well, I think probably the most common misunderstanding is that if they really cared for and loved their baby-to-be, that they would be able to stop using drugs or alcohol.
Mm-hmm.
We know that addiction, the salient feature of addiction is continued use despite adverse consequences. We know that compared to other behavioral health conditions, addiction is more stigmatized than other mental health disorders, and that's persisted across decades of research. And that's in general. But then you have addiction plus pregnancy plus fetus plus, continuation of society. And probably amongst the most stigmatized people are pregnant women with use disorder. But I don't like the term stigma. I think it's a euphemism. And frankly, when we treat people differently because of a condition, such as addiction or pregnancy, that's discrimination, and that's prejudice. And the roots of discrimination and prejudice, we know, are ignorance. And so the idea that drives it, and what we're doing here and what all of us do like day in, day out is about treating people with dignity and respect, understanding the science and the condition, and intervening within given parameters to improve health.
Can you talk a little bit about how language affects our understanding?
That's a great question. So you can think about the words we use as they should be scientifically accurate. They should, be the terminology of the day. And so the current terminology is addiction or substance use disorder. But the other thing language does is influence how other people think about what we talk about. So when we use terms such as substance abuse, which was the DSM-IV definition, there are randomized controlled data showing that people who read vignettes in which an individual is referred to as a substance abuser are less likely to endorse a public health or response and more likely to have a punitive response and label this as something that's a disease of their will. And at the root of all of this is what we talk about as person-centered care and person-centered language. So people aren't addicts. We don't define people by their illness states. There are people who use drugs, people with addiction, people with substance use disorder, people first.
Are babies born addicted?
Oh, that's another great thing. So addiction is a brain-centered condition, affects the whole body, but the symptoms are primarily behaviors. Craving a substance, compulsive use, unable to stop using something, trying to quit but being unable to. There is nothing about a baby that could be addicted. Addiction is a chronic condition. Chronic conditions cannot be present at birth. What infants have, both from in utero opioid exposure, from methadone, buprenorphine, heroin, any opioid, they can develop withdrawal. So withdrawal is a physiological, biological principle. It means biological symptoms present upon cessation of a substance. That is true of opioids. That is true of hypertensive medications. That is true of SSRIs. That's true of most medicines we use. So the presence of withdrawal, which is a sign of physiological dependence, is not addiction. It's a biological response. It's not a behavior. And so the behaviors of addiction, craving, compulsive use, continued use despite adverse consequences, those make no sense in a baby. And
Thanks, Dr. Turpin.
Addiction, addicted babies, is not only scientifically inaccurate, but it's judgmental and actually harmful to the care that new families need.
Okay, thank you. Judge Raleigh, can you talk a little bit about working with your team in the court to work with folks with substance use disorders and address any issues that might arise around stigma?
Yeah, this is a very important issue, and I think it's important to recognize that even for myself, I've had to challenge my beliefs. I've had to educate myself. I'm a person in long-term recovery. I'm a person who understands the addictive potential of opiates, but if we separate out someone who has a broken leg and takes their opiates prescribed by a doctor and then develops an addiction as compared to somebody who starts in some other manner and then is shooting heroin, we'd say, well, you know, too bad for that person. That was really unfortunate. Maybe the doctor mismanaged it, but the person who ended up using heroin, they're shooting heroin, we see them as a completely different person. The more we learn, the less misunderstanding there should be about opiate use disorder, and we are learning a lot. For example, if you start talking about the ACEs research, which most of us are familiar with now, the Adverse Childhood Experiences research, I just was going back to look at some of that. The single biggest correlate to addictive behavior is a mother with significant childhood trauma. So as you record the number of childhood traumas a mother has, the more likely she is to be addicted, and that includes injection drug use. We know that childhood trauma actually causes measurable damage to the brain. If you think about it in that way, the mother's use of opiates like heroin is a coping mechanism. It's a way to deal with the pain and distress of her life. So now if you're talking about somebody who is addicted, and we have to be clear about what it means to go through withdrawal. People talk about withdrawal in such clear and horrifying terms, the worst flu they've ever had, or 10 times the worst flu, or 100 times, or 3 days of it. So there's so much behavior that is connected to avoiding detoxification, and it leads to so many desperate acts, especially if there's no heroin available or no other drugs available. Then we get talking about things like survival sex or transactional sex, where women and men are engaging in sexual behavior in order to avoid detoxification. And you take all of those, and it's so easy to judge those folks. Now when you start asking those folks about why didn't you get prenatal care, and that's where a lot of the judgment comes in. Someone has a positive tox baby, maybe premature, so how come you didn't get prenatal care? That's where our judgment is that they don't care. They don't care about themselves or their babies. But in fact, we don't give them good opportunities. I've even heard not only the nice OBGYN office in our community, where women do not feel welcome when they come in there and they've got scars on their arms, and somehow their condition reflects the fact that they're not a middle-class parent with health insurance. But even at Planned Parenthood, where it's a couple hours of paperwork to fill out and a requirement that you come back for additional appointments, those are all points of resistance. Those are obstacles to people getting the help that they need. I want to say one other thing, because this is really my soapbox. When you're talking about the brain science here, we're talking about the reality that opiates bind to the same receptors as those that relieve physical and emotional pain. That's why it helps for the broken leg. That brings joy and elation and the feelings of well-being that we all crave. That's why they call it the love molecule. Persons with opiate use disorder often describe their first use of heroin as like a warm, soft hug. So if you're experiencing that physical pain, that emotional pain, that disconnect from community, that connection between mother and child, that heroin feeds all of those needs. And we just have to understand how compelling, how overwhelmingly compelling this opiate use disorder is. And that gets rid of all the judgment. These are people that need help, not our prejudice.
Thanks, Judge. I'm watching, we're going to shift and talk a little bit about medication-assisted treatment. I see lots of questions that are just rolling in about what types of medication, why to use them with pregnant women. I'm going to start with you, Dr. Turplin. So can you talk a little bit about the efficacy of using MAT during pregnancy and post-pregnancy? And is it safe for the baby?
So one large principle of maternal-child health is that healthy babies equal healthy mothers equal healthy babies. And another principle is that we want to treat chronic conditions. We want to optimize maternal health during pregnancy that optimizes birth outcomes. That's true of hypertension, diabetes, epilepsy, and addiction. So the important distinction is really between the risks of untreated addiction versus those of treated addiction, not people with addiction versus a population of people without addiction. That's like comparing people without diabetes to people with diabetes. It's important to know what your comparison group is. So the evidence-based practice for opioid use disorder, the treatment is pharmacotherapy with either methadone, buprenorphine, or naltrexone plus behavioral counseling. And the same principles apply in pregnancy. We just know a lot less about naltrexone. So the two recommended medications are methadone or buprenorphine. Now, the risk to the fetus is really of untreated addiction. As the judge described nicely, somebody with an opioid use disorder, shortly in the development of their addiction, their drug use is no longer about that warm, fuzzy feeling and that sense of connection. It's about self-medicating withdrawal. And anything that you inject, and most opioids that people become addicted to are short-acting. So people with an opioid use disorder are using opioids 3, 4, 5 times a day and going into withdrawal like 3, 4, 5 times a day. And just as mom is going into withdrawal that many times, so is the fetus. So the risk of preterm birth and low birth weight that we see in a general literature are really attributed to untreated addiction, to the stress on the fetus of repeated cycles of withdrawal. Both methadone and buprenorphine are long-acting opioids. They're dosed daily or twice a day. And that provides stability, not just for mom, but also for the fetus. And that stable intrauterine environment allows the fetus to grow normally. So we see women who are on pharmacotherapy for opioid use disorder in pregnancy, they are much more likely to deliver at-term, normal weight babies. In fact, their birth outcomes are almost identical to a population of women without addiction, and very different from birth outcomes amongst women with untreated opioid use disorder. So
Can you talk?
Yeah, go ahead.
I was going to say, can you talk a little bit about the treatment of the infant after birth and best practices?
Yeah, so there's two things. One is what I mentioned before, a distinction between addiction and dependence. So newborns are not born addicted, but they can be born dependent, and they can develop withdrawal after birth. So any infant who is born to a mother who used opioids for any reason during pregnancy will be observed for up to 5 days. It depends on the opioid and et cetera, but let's say roughly 60% of opioid-exposed infants will develop withdrawal. Mm-hmm. No, it's actually complicated. It's more than the opioid. We know that there are probably the greatest determination of whether an infant develops withdrawal or not has to do with whether or not the fetus's mu-opioid receptor has a methylation or not, i.e. it's genetic. And so that means we can't control it. We know it's not related to maternal dose, so higher doses of methadone or buprenorphine do not mean more likely withdrawal. And we know that there are other co-occurring things that make withdrawal more likely and more severe. And by severe, I mean the infant stays longer in the hospital and receives medication or more medication over time to treat. And those things are moms who smoke cigarettes, moms who are on other medications, mothers who use other substances, And also the caregiving environment after birth plays a very big role. Breastfeeding, even skin-to-skin contact, or even breast milk reduce the severity and duration of neonatal abstinence syndrome. Moms who are allowed to room in with their infant in the same space after delivery, NAS is less severe and of less duration. And hospitals that have protocols for the evaluation and medical management have shorter, less severe NAS than those without protocols. So finally, like, how is the infant treated? So the infant is observed. One would begin with non-pharmacologic management, i.e. holding the infant unless there are contraindications in which pharmacotherapy, methadone or buprenorphine are not contraindications for breastfeeding. In fact, they are encouraged. Breastfeeding should be supported among women with treated opioid use disorder. And then as the infant is scored on a schedule usually, and if it displays signs of withdrawal, might be medicated. And the medication actually depends upon the delivering hospital, and there's a whole lot of new research on this. The medications that are emerging as being, probably the top medications, buprenorphine in some places, and methadones. And methadone seems to be superior to morphine. And then there are other medications that are even less evidence-based, like phenobarbital, which is an anti-seizure medicine, tincture of opium, which contains alcohol in it. So the medications used to treat are actually quite critical, and this is an area of a lot of research at this point in time. If the infant develops signs needing medication, the infant will be medicated to stabilize the withdrawal, and then the medications are tapered.
Thanks. I'm going to put a plug in here, too, for the opportunity to use the plan of safe care prenatally. So ideally, that OBGYN will be working with that mom and recognizing that there is substance use or that mom is taking medication-assisted treatment. So there's an opportunity to work collaboratively with that medication-assisted treatment provider to start developing that plan of safe care. That could then be handed off to child welfare if they become involved after birth, or that team can continue working with that mom after the birth on that plan of safe care. Judge Rowley, I know that you have successfully supported Matt in your courtroom. Can you talk a little bit about what challenges your team encountered and what advice you would have for other FDCs who are still struggling with Matt?
Sure, thanks. And it is a process, and it was a process for us. And I think that the survey you gave is a great example of how to have the conversation. We really need to uncover our beliefs, our misunderstandings, our confusion, our prejudices, and just say, we got to put these on the table. Let's start with that conversation. I had a thought today that I thought was quite clever. I think that MATs should be considered a gateway drug. They're gateway drugs towards access to treatment and recovery. You've got to go through that doorway to get to the hope of parenting and reunification, and there is a lot of hope if we can get there. It hasn't been easy at all. New York State's been a real leader, at least policy-wise, in recommending and actually mandating the use of MAT in the drug courts for quite a while. But that doesn't mean that there was any magic with that. I think we still have inpatient treatment programs that will refuse admission to somebody who's currently on Suboxone, and we certainly have people who are being released from inpatient treatment who are not being released with Suboxone. Doesn't happen as much as it used to, but there we are. We've got something that we know works, and it's not always used. So let me just note a couple of the obstacles that we've had to face. Very slow adoption of the MAT. The various treatments available. Vivitrol, for example, the once-a-month shot, took a long time. It's expensive. It hasn't turned out to be as effective as we had hoped, but it is an option, and for a long time it wasn't just available in our community. We had to continue to push. We had to engage the doctors at the treatment agencies. We encouraged our parents to ask for the medication-assisted treatment to kind of push in that direction. But we had to do a lot of changing about our understanding too, as did the doctors in treatment. Initially, Suboxone was so tightly regulated, and as far as methadone is extremely tightly regulated. And we have people taking a cab an hour each way every day, 6 days a week to get their methadone because you can't establish a clinic in New York. I don't know about the rest of the country. But even the Suboxone, the numbers that doctors could have was so tightly prescribed, and they guarded their license so closely that if you diverted your Suboxone, you were likely disqualified from further Suboxone treatment. And you start thinking about that in the perspective of what's really going on here, and that's crazy. One doctor gave me so that's the equivalent to a doctor denying a diabetic person their insulin because they caught them eating a donut in the waiting room. So somehow you're breaking protocol, so you don't get treatment anymore. That's also led to, so we've had to change our mindset about compliance and go to really virtual, unconditional support. If you're not complying, we want to know why you're not complying, but we're not going to consequence you. There's not going to be a negative for that. It's a re-engagement model. And that also, I think an important point to state is that we do not use jail sanctions in connection with any aspect of NAT treatment. Even a person who's standing before me who is in bad shape with heroin, is currently using, admits that they're using. And this is a medical issue, not a criminal issue. These are all civil courts in New York, and we don't incarcerate people for being sick in other arenas. If someone comes in and said that their depression is so bad they're considering suicide, or someone with alcoholism says that they've drank again and they know that this might cause serious injury or risk to them, those are health crises, not moral crisis, and we will not use incarceration for the integrity of our program, and really I think just for I think it's just the right thing.
Mm-hmm. Nice. I'm seeing more questions roll in. You know, something comes up in my mind around working with methadone programs and MAT providers. I've traveled across the country and worked with lots of court teams and other teams trying to address infants with prenatal substance exposure. We oftentimes include our substance use disorder treatment providers, but the MAT providers aren't always at the table. I think there's a lot of reasons for that. There might be issues just, they sometimes feel like me, that they feel like sort of the black sheep of the substance use disorder treatment world, and we need to do some rebuilding of trust and relationships with them to invite them to the table. They have a lot of information. They're working with our clients every day. They see them every single day, and they have information to be able to support those clients. I also think they're doing a whole lot more work around supporting women who are pregnant in terms of sharing information with birthing centers and hospitals and OBGYNs. I know some folks are asking questions about what do you do if a methadone provider is the dose is just increasing too rapidly, or I'm seeing symptoms in my client, and I would suggest building that relationship and starting to information share to talk about what's going on. I don't know, Judge, would you add anything to that?
Yeah, I would. I think that's a great point. It's exactly the experience we're having here. I mean, we had a director of an outpatient treatment program accuse our agency, which is much more focused on MATs, of substituting a drug for a drug. And that's a common statement that's out there. I just was surprised to hear it from a person in this experience. I think it's an important question to answer. We're talking about people who are exhibiting significant maladaptive behavior, high-risk behavior. We're talking about the transactional sex, we're talking about theft, we're talking about all sorts of problematic behavior, and we're replacing it with dosage of medication prescribed by a doctor in a medical healthcare facility, which then becomes the gateway drug towards treatment. And then they'll make the medical decision about whether or not they're going to continue on Suboxone or methadone. We don't have to worry about whether this is a lifetime choice, even though it's a legitimate one. It may be a 6-month choice, but that we have exactly that resistance in our community between what is considered the harm reduction model versus the treatment model. These are all harm reductions. We got to break down the barriers between us.
The other question I often get is I have a client who's on MAT, but they're still using another substance. So maybe they're still using cocaine or something else. Again, remember, it's medication-assisted treatment. So it may mean that that client needs a higher level of care. So might need to pair inpatient treatment or residential or even intensive outpatient to support them a little bit more as they're moving into recovery. Dr. Triplin, anything to add on this subject before we move on?
Yeah, I mean, there's a lot of comments on this in the subject box also related to breastfeeding and how long to treat somebody for, related to dose increases. So this, what should be done is due to the physiologic changes of pregnancy, in particular in the later second and third trimester, it's not uncommon for somebody who is stable on a previous dose to become symptomatic, that they need a higher dose or a split dose, which means twice daily rather than daily dosing. This appears to be more common with methadone than with buprenorphine, but can also be seen with buprenorphine. The big picture is that this is individualized, and it doesn't mean that everybody needs a dose increase. It just means everyone needs person-centered care to be evaluated to see whether or not their current medication is sufficient. And then if somebody's been dose increased, they might need to be dose decreased following delivery, and it's the same principle. Like person-centered care, there's not a magic point in time in which you switch back, you gradually decrease back. And some people, and there's not a relationship between the severity of the addiction and the medication dosage. I have patients, stable on very low doses and patients who need much higher doses. And so this is true of other medicines that we use. Clinically, we have an evidence base, but we apply it in a person-centered moment. And so every individual is different, and we find the dose that's right for them. I think there's a lot of misunderstanding around medication, and this happens in particular in the postpartum period. It's not uncommon for clinic staff to say, like, this new mom who is, a client of a methadone clinic is nodding off. Her dose must be too high. And I say if she's dosed correctly, she shouldn't feel anything. There's no euphoria. There's no, it's stable daily dosing. She's a new mom. She's got a lot of reasons to be nodding off. She's got a newborn at home. She could be tired. She could have an infection. And this is actually how our stigma leads to worse medical care. We make assumptions about individuals clinically based upon a diagnosis of addiction or addiction treatment that leads us to be blind to other things that might be going on and could be treated. In terms of breastfeeding, it is recommended, and I'm happy to share, American Academy of Pediatrics, the SAMHSA recent guidance document. Everybody recommends breastfeeding for individuals who are stable on pharmacotherapy and don't have other contraindications. And then the final question which comes up, which is how long should somebody be on medication for? Mm-hmm. As long as you need to be. There's a lot we don't know about the life course of addiction and opioid use disorder. We use a singular term, but it's probably a plural condition. There are people who need pharmacotherapy forever, and if they go off the medication, the disease will recur. There are other people who you stabilize over a period of time, their disease goes into remission, and it never comes back. And then there's everybody else in between. And clinically, we actually do not know a priori who's going to be in which of those categories, and there's probably more than 3 of them. And so it's really, and this is where evidence base is that at least, 18 months to 2 years leads to sort of reparation of the dopamine system from brain imaging, but it's individualized. And really as long as we need to. I like the judge's way of thinking about, pharmacotherapy as a gateway. The way that I sometimes talk about it is that the goal of treatment is not more treatment. The goal of treatment is recovery. And recovery is highly individualized. There's as many paths to recovery as there are people in recovery. And medication and treatment is an important part of that. But the goal, we should keep in mind what the goal is, which is recovery.
Great. So one last question for each of you, and I'm going to start with you, Dr. Turplin. What do family treatment courts need to know about working with the healthcare system to support pregnant women with opioid use disorder?
What do they need to know about the healthcare system?
How about OBGYNs? How about working with their OBGYN
broken and inefficient and not person-centered or provider-centered. I think probably the most important thing is what the judge alluded to earlier, which is the importance of getting to know people, names to faces, and it's bidirectional. I know I work with so many colleagues, physicians, who've never stepped inside of a methadone clinic, much less known anybody who worked there. So I think it's really important to make connections, and I would start with the birthing hospital. Like with the local birthing hospital, there should be a relationship between family drug court and the local birthing hospital. And the social worker on the birthing hospital is on labor and deliveries and or postpartum is a great place, or NICU or newborn nursery, great place to start. And then getting to know who the larger providers are. And I found everywhere I've ever been that I've yet to go to a hospital system or a clinic and not find somebody who is, a champion of this topical area. So start with the birthing hospital, find the local champions, and put names to faces.
Thanks. A lot of the states that we worked with in-depth technical assistance really found that they didn't know what was happening within the healthcare system. So lots of questions that they went to their providers to ask about, were they using substance use disorder screening? How was substance use identified in pregnancy? If they did identify substance use in pregnancy, what was actually done about it? Because there are oftentimes those real difficulties in terms of connecting those and with treatment.
Yeah, so one thing, and this has been alluded to as well, in the United States, most women with a substance use disorder do not receive any treatment for it during their pregnancy, much less postpartum. So, and I have yet to work with a pregnant woman with a substance use disorder who was not motivated to maximize her health and that of her baby-to-be and not to want and seek treatment. But in many places, it's actually not available. There's also, we do not, even though the guidance document says we should do universal assessment of substance use, misuse, and addiction as a routine part of prenatal care, that is not universally happening in the United States. So there's multiple missed opportunities. I think something really important to think about, and this would be in particular for states that did not expand Medicaid, is that health insurance, most pregnant women are eligible for Medicaid during pregnancy, and it turns off up to within 60 days of delivery. And that can be a huge barrier for the continuation of addiction treatment services, any kind of medical care, newborn care, and this is a massive stress on a oftentimes already stressful postpartum period.
Thanks, Dr. Sherplin. So Judge Rowley, I'm seeing questions come in saying, what does all this have to do with the courts? Can you talk a little bit about how the courts could use this information and to build collaboration to support pregnant women and parenting women?
Sure. Quite a long time ago, the district attorney challenged our drug court model, saying, why do we have all these treatment people and social workers in the courts? And it seemed like an easy, obvious answer because we have all sorts of tremendous needs. I mean, the majority of our cases are impacted by substance abuse and related criminal behavior or other, as I said, maladaptive behavior. It's all about being effective. I mean, courts, the whole drug court movement reflects the frustration of judges and court systems of being on the sidelines. And we have got all those questions in front of me now, but I'll just keep talking. There we go. To be effective, we've got to be engaged, and this has all been about judicial empowerment. And we talk about wanting to empower our parents so that they feel like they can be engaged in the community, they can have an impact on their lives and their children's lives. Well, the courts were stymied as well. Now we are using our authority to convene. That means to convene in the community, our power to persuade. And I think we're also emphasizing our responsibility to challenge the status quo. So if I For example, this has prompted me to say, you know, it's overdue for a meeting with the OBGYNs. Well, that's a little intimidating to me, but if I send out a letter inviting OBGYN, first of all, as Dr. Turpin said, make a few connections. I know some of the OBGYNs, make a connection, get some guidance, send out an invitation, and then a personal phone call. I say, look, we're going to have a meeting. There is a power to convene that the court has, that the judge has, and most people will respond to it. And then when we get in the same room, I'm pretty good about persuading. You know, that's why I'm in the role that I'm at. And I feel like I have the responsibility to do that. And I think one other point that I want to raise that really has been helpful from Children and Family Futures training that I've got is that we are not at the mercy of these healthcare systems or substance abuse treatment system or hospitals. Our parents and our programs are clients of them. And as clients, we're entitled to demand a response to our needs. And instead of saying, oh, I wish we had more same-sex specific groups, you know, why do we have all mixed-sex groups? We said, you know what, we need more same-sex groups or we're going to have to shop elsewhere. And it's a whole change of mindset, which I think is extremely important because the needs are not necessarily being met. Old models are not meeting current needs.
Mm-hmm. Thanks, Judge. So lots of questions rolling in. We're going to actually sort of open it up to do a bit broader Q&A. I've seen several of them come in. There were actually quite a few questions about women who become incarcerated and taken off their MAT. I don't know, Judge, if you want to address that, or Dr. Turpin. Sounds like you're tuning in. Mishka, jump in.
Sure. So this is women who are on pharmacotherapy who get arrested and are basically involuntarily detoxed off of their medication.
Correct.
So other judges know this more than I do, but there's prisons, there's jails. It's a very heterogeneous landscape, especially when it comes to jails that, and this is not meant disrespectfully, but really operate as healthcare fiefdoms of the elected sheriff oftentimes, who some are supportive of pharmacotherapy, some aren't. All of them have limited budgets in which they have to, create healthcare for their incarcerated populations. It should be noted that the only population of people actually in the United States with a constitutional right to health care are prisoners. That doesn't mean that quality of the health care is great always. So there's market heterogeneity. Some methadone clinics have guest dosing relationships with jails, others don't. There's a jail that I went to once where there were two local methadone providers. One had a guest dosing relationship, the other didn't. So depending if you were in one clinic and you got arrested, you had involuntary detox, and the other clinic you continued your medication. I mean, all of this is patently absurd. And there is guidance, and this is more for federal health, federal administered prison systems have guidance around this, but that's a minority of people. So I think that this is an example of where the only forward action is actually through working locally with your primarily your jails to ensure evidence-based practice is for all people, including incarcerated.
Mm-hmm. So another question that came in that sort of is around that evidence-based practice as well is when clients go to seek methadone treatment, oftentimes methadone treatment is not coupled with therapeutic substance use treatment, and it oftentimes ends there. So we often see this happening out in communities. Again, I think there's a lot of reasons why that happens. Sometimes it's complicated by the structures, but we really want to see those clients who are going in to receive some kind of medication-assisted treatment coupled with substance use disorder treatment. We are seeing more and more MAT programs starting to bring up programs, so maybe an intensive outpatient program or something like that. But there's also models out there. You often hear about hub and spoke models where clients will be referred out to get that substance use treatment, and that MAT provider will sort of oversee the broader case. So again, sort of an opportunity, especially for family treatment courts, to come together and to advocate for everyone to be at the table and to ensure that those clients get all the services that they need. Anything to add, Judge Raleigh?
Yes, actually, that's another issue that we have addressed specifically. I mean, the extreme of the harm reduction model is simply to provide access to people so that they'll stay alive. And that's very effective. That is not enough for parents who are trying to reunite with their children or have children at home. And that's that's the conversation we're having with our primary MAT provider, saying that, you know, we need stabilization so then we can move them effectively into treatment programs. We have some support for that. One of the rubs is at the point of other medications, for example, gabapentin, which is commonly prescribed to people in this situation, but we find often abused and can become a barrier. So again, it's back to relationships and communication, but I think that it's important to differentiate between trying to stop the dying and trying to identify people who actually have a lot to live for beyond just stop their using, but actually will be able to re-engage in their lives if they continue to take steps after the stabilization.
One more for you, Judge Rowley. Can you, were you going to jump in, Dr. Turplin?
Yeah, I was just going to add one group that's an important partner that we haven't mentioned are the payers. So most pregnant women have Medicaid. Most Medicaids now provide care coordination services. And although it's not counseling, but they can help with sort of organizing the navigation between different clinical responsibilities, as well as providing resources for some of the psychosocial supports that are needed, you know, for really the comprehensive addiction disease management.
Yeah. Good add. Actually, one of the states I'm working with for in-depth technical assistance is using their Medicaid care coordinators to develop and implement and oversee the plan of safe care, and it's been a really fantastic matching of services. Judge Rowley, a question came in for you. Can you address a mother's right to use MAT under the Americans with Disabilities Act? And can courts require a mom to stop using MAT?
No.
In order
no.
to
No, I don't have any official position on that. I think we will soon be, I mean, 5 to 10 years, we won't be having this discussion. I think this is an absolute right to seek medical treatment. And as far as the option to stop, that is an absolute right as well. It just has the natural consequences that it does if it leads to instability that just keeps going on and on. But we've got to move this out of our criminal, civil, legal realm into healthcare, and these are rights to healthcare, and we got to get rid of the obstacles so that there's not so many barriers just to getting basic medical care.
Thanks, Judge. Dr. Turplin, tapering question. So lots of people asking if it is safe to taper opioid use during pregnancy, and are there any studies specifically on tapering?
Great question. So tapering would be, so we sometimes use the term detox, medically supervised withdrawal, medication, you know, assisted withdrawal, taper. It would be a dose decrease from wherever somebody is to nothing. The motivation for that from a population health perspective might be the no neonatal abstinence syndrome. The risk, which has been alluded to, is the risk of relapse and untreated addiction and co-infection with Hep C, HIV, disengagement with prenatal care and stuff like that. So I recently completed a systematic review looking at quote-unquote detoxification during pregnancy, and there were about 2,200 participants in all the studies worldwide that we looked at. And what we found was that contrary to initial early reports from the late 60s, early 70s, detox does not seem to be associated with fetal demise. That means loss, like in utero demise, stillbirth. But it is associated with relapse, and it does not appear on a population health benefit to actually decrease the rate of neonatal abstinence syndrome, because if you stop treating a condition, there's a likelihood of recurrence and untreated being worse than treated disease state. There are there's really only 2 articles that really did, I think, a comprehensive job looking at tapering. And these were more so-called choice trials, so women could choose to taper. And within those, about 60% of women who elected for taper management through the course of pregnancy changed their mind during the taper and then elected for continuation and maintenance dosage. We were just awarded a grant to actually look at this more rigorously. So in 5 years, we might have a little bit more data, but right now that summarizes it.
Thanks, Dr. Turplin. I'm seeing some questions about the plan of safe care and who should oversee those plans of safe care. I think that, again, that the CAPTA legislation doesn't specifically say who should oversee plans of safe care, but definitely there's some decisions that are rolling out from state collaborative groups around plan of safe care oversight. I mentioned earlier we saw one state using Medicaid care coordinators to oversee them. I've seen in many states very significant partnerships with substance use disorder and MAT treatment providers to oversee plans of safe care, and certainly child welfare also has a role in overseeing those. Somebody else asked if how to incentivize the plan of safe care for healthcare providers. We think, oftentimes we hear from healthcare providers it's really difficult, especially if child welfare doesn't open a case on an infant, that maybe there are some other concerns going on with that family, that this plan can be a support to be able to bring providers together to continue to engage that family. So my last question to both of you is, how do you think the plan of safe care could support collaborative efforts working with pregnant and parenting women? Judge, can I start with you?
Sure. We've got a legal barrier in the sense that our social services departments have no right to involve pregnant women. The problems start at birth. It kind of doesn't make much sense, but it just means that at least for the time being, leadership is going to come elsewhere, which may be just as well because, of course, DSS looking over the shoulder is often a barrier. Ideally, I think that our health department would be the convener of this. This isn't happening actively, but it's exactly what we're doing in family drug court. Is just moving the timeline back. I mean, the basic things like what is OBGYN practice with regard to drug testing, and what engagement is happening, what conversations are happening. Should we be considering this a routine thing? I mean, should all women be screened at this point? And then what's the referral process? So I think we do have to move this back in time, and then from there, upon birth, we need to expand our options. It doesn't require a neglect case necessarily to have a plan of safe care, but many of the systems, many of the services within our care system would be involved in one way or another. So we've got work to do, but I think it's manageable. It's just it's a new concept, although it certainly makes sense.
Thanks, Judge. Dr. Turplin?
Well, I think that there's, on the part of obstetrician, gynecologists, and other prenatal care providers and birthing hospital staff, there is a lot of confusion about the plans of safe care and reporting and et cetera. There are also very meaningful differences by state in terms of what the consequences are of the report. Whether or not exposure is codified within state statute as equivalent with child abuse, and versus states that don't. That has some serious consequences. I would, like to take a step back, I think, as well, and think about just the postpartum period, which is a period of increased vulnerabilities for all women, including those with substance use disorder. And I do think that there is a role for a universal social work assessment, for all birth moms to assess home environment need, resources, et cetera. And that would actually be a very effective way of reducing, the stigma associated with child welfare involvement only in cases of maternal substance use. But that might not be politically expedient or or whatever. But I think that's really like the most sort of whole person, whole family path forward. And just because I'm on this postpartum thing, I think this is a really important point which we haven't gotten to yet, so I'm going to say it, which is we talk about maternal mortality, and maternal mortality has been in the news a lot lately. The U.S. has an increasing rate of maternal deaths in contradistinction to all other developed nations. There are marked racial disparities in maternal mortality, and the states that have looked at the contribution of the opioid crisis to maternal mortality, it's shocking. Many states, the leading cause of maternal death, and that is defined as a death from conception or when somebody is aware they're pregnant to 1 year after delivery. Opioids are the leading cause of maternal death in many states. And most of that is due to overdose, and almost all of those overdoses are happening in the postpartum period, in particular in the later postpartum period. So this speaks to the importance of continuing care. Addiction is a chronic condition. We treat chronic conditions through chronic disease management. And care does not end. Medical care should not end, nor should health insurance end, at delivery or immediately postpartum. So I think one of the ways plans of safe care can be super helpful is the linkage and continuing support of moms with new babies into and through the postpartum period. So really ensuring continuation of addiction treatment services, pediatric visits and other medical care things. So that linkages that need to be established, they're going to work much better if they are established during prenatal care than if they're established, immediately post-op, post C-section, a new environment for the mom with provider she's never seen before, and the baby's in another tower of the hospital in the neonatal intensive care unit. That's not an easy place to make a therapeutic alliance to better the health of the family over the next 12 months.
Thanks, Dr. Triplin. Yeah, it reminded me of lots of states also considering that with early intervention providers, and oftentimes women have so much going on at the birth event, and that early intervention provider comes in and it's just too much, and they often don't take them up on that offer. So how can we get EI in early just to sort of get a little bit more transparency and drop down some of those barriers so that they'll engage after the birth? Such a rich topic. We have so much to talk about, and unfortunately are coming to the end of our time today. Let me highlight just a couple of resources for you. We have the collaborative approach to treatment of pregnant women with opioid use disorder. It's a really fantastic cross-system guide, has a lot of discussion about best practices, and also includes some really good surveys. So if you're unsure what's happening in your community, this is a great way to start asking the right questions to find out what services pregnant women are receiving. The next document is the Plan of Safe Care Planning Guide. So this is really a step-by-step guide for how states can implement the Plan of Safe Care to really start sort of up at state decision makings around even legislation and policy, all the way down to developing that actual plan and implementing it in your community. Really fantastic source. I think we have one more. The clinical guidance for treating pregnant and parenting women with opioid use disorders in their infants. Really fantastic. Dr. Triplin worked on that as well, so we highly recommend that document. And all of these you can download today or you can find on the National Center website. So again, you can find lots of resources on the Children and Family Futures website. You can always shoot us an email at that address there, and we can reach back out to you with whatever resource you're looking for. Big thank you today to OJJDP, to Judge Rowley, and Dr. Triplin. Thanks so much for participating today. And I'm going to turn it back over to William.
All right, thank you, Jill. And just as Jill had just mentioned to everyone, you can contact National Family Drug Court TTA program and Children and Family Futures at the following contact information: FDC at cffeatures.org or visit www.cffeatures.org. And just a quick reminder to everyone that the webinar recording will be archived in approximately 1 week on OJJDP's Intact YouTube channel, and supporting resources can be obtained by contacting OJJDP's help desk on the contact information here. And also, just a reminder to everyone that you can also contact OJJDP's Intact through our website displayed on this slide, and you can also stay up to date on the latest information by signing up to OJJDP Intact's TTA listserv. Also, don't forget to like us on Facebook at OJJDP TTA on Facebook.com. And you can also connect with or contact OJJDP directly by visiting the help desk on this information on this slide here, including our telephone number and OJJDP's website. And last but certainly not least, I wanted to remind everyone to please just take a few minutes to complete the feedback survey to help improve our future webinars. Thank you all again for joining us, and have a great afternoon. Bye-bye.